9 out of 10 times the medicine handed over is actually an antibiotic. The patient doesn't know about it, they don't have a prescription. As a result, rural India is dangerously becoming antibiotic resistant. Somebody had to do something about it.
There's a lot of upfront investment to become a doctor. You need to recover that investment by working where the money is, and the money is in urban areas.
The only difference is here the doctor is not available physically but available digitally.
Priyadarshi Mohapatra is the founder of CureBay, a health tech startup delivering high quality primary care to 1.5 million Indians through a network of 200 village level eClinics.
Imagine meeting a super specialist of a very large hospital sitting right at your village, especially when your case history is already known to him because you have been examined and your records have been shared.
This sounds too good to be true.
If somebody wants to copy my model, I'll welcome that entrepreneur to come sit with me and give them every bit of my learning because I believe there are 100 CureBays required to solve this problem for a billion people.
Priyadarshi, welcome to the Founder Thesis podcast. You run a health tech startup called CureBay. You've raised a ton of money. I want to first understand, I want to take a zoom out, zoom in kind of an approach. Help me understand what healthcare in India looks like. I mean, there are different parts within healthcare. What do you mean by primary, secondary, tertiary? What all is happening? And then within this landscape, where does CureBay fit in?
Sure. So, actually, let me give you an overall picture of the topography of healthcare in India. And if you look at it, there are two distinct parts to this topography. One is the urban healthcare setup, and the other is the rural healthcare setup. Urban healthcare setup in India is actually pretty world class because we have very high quality, high end tertiary intervention centers, whether it's the
What do you mean by tertiary? Just define that.
this is where a patient sort of gets an intervention, which could be a surgical intervention, or they're admitted in the hospital, and there is some interventions which are being done on the patient, which could be from surgical processes to observations under a long period. And then you have secondary healthcare, which is where you get these minor cuts, or you have a broken hand and somebody needs to plaster or do this. But again, there is some feature functions which are getting done on the body of a patient, right? And then you have primary healthcare where basically you come for your first level of concern, right? You meet a GP, you said you're having a bad cold, you're a fever, you have a conversation, you're asked to do some medication. Typically, how the journey happens is you get referred from a primary healthcare center. If you need it, you're examined, you're checked, and then from there on, you get referred to tertiary centers. But what has happened in India is if you see, our healthcare infrastructure is pretty much skewed towards urban India. I mean, we have 30-40% of the population living in urban India, but close to 65% of all healthcare infrastructure is skewed towards urban India. Whereas rural India doesn't get their fair share of healthcare infrastructure. Now, to be very honest, I think kudos to the government because in a complex geography like ours, to make healthcare reachable for over close to 100 crore people living in rural India is not a joke, right? And government has created a five-tier healthcare infrastructure, right? It starts with the district headquarter hospitals where you can get the tertiary interventions. Then you have community healthcare centers which can take care of primary and secondary, and then you have primary healthcare centers, which typically are the first point of contact for a lot of people living in rural India. And the challenge as a country that we have not been able to solve is to ensure the availability of providers in all these places, right? So if you walk into a district headquarter hospital, even in a rural market or slightly interiors, you will find doctors available there, right? But as you go down the value chain, as you go to the community healthcare center, primary healthcare center, you'll find a lot of places don't have doctors. And this is where the patient journey in India sort of gets challenged, right? Whereas people like you and me, I think we're really privileged. We live in urban pockets where we directly walk into a tertiary facility a lot of the time, even for our primary requirements, because every tertiary facility will have an OPD, outpatient, which is where most of the primary intervention happens, right? That sort of will give you a good view of how the healthcare infrastructure itself in the country is skewed more towards urban, hence creating a challenge for rural India.
I remember some of my younger cousins were pursuing like an MD, and there was some requirement of a mandatory rural stint. Does that not help in solving this problem? And what exactly is that requirement of a rural?
Yeah, great question. I think, actually, government has tried everything from the carrot to the stick. There is incentive to go and do rural practice to government making it mandatory that if you're passing out from the government colleges, you have to spend 2 years in the rural facilities offering you services. Now, the challenge is more social than any kind of mandatory regulation. Because if you see, the reality is only 1% of people probably get through PG seats through
Hmm.
government colleges through competitive exams. The rest of the people getting into PG actually go through a very high capitation fee into private institutions. And for them to go and sort of service the loan that they have taken to fund their education and practice in rural India creates a kind of dichotomy which remains unsolved. Hence, there is a natural resistance to go and practice in rural India.
There's a lot of upfront investment to become a doctor.
Yeah,
You need
yeah,
to
absolutely.
recover that investment by working where the money is, and the money is
And
in
that's the
rural
reason
India.
why I said, listen, whatever we do in terms
Hmm.
of creating policies, design, market forces will always rule. Somebody has paid a huge sum of money for an education course, and they need to figure out a way, even if they have the best intent to pay back. If they are reeling under the debt trap, how will they offer the right kind of services to you? And healthcare is something where you require a lot of empathy. So when you yourself are pressurized, how would you expect them to extend that empathy to others?
And these five-tier government centers are largely free, I assume.
Yeah, most so India behaves like a welfare state,
Hmm.
okay, and a lot of the healthcare facilities that we offer to people through the government infrastructure is actually free. Okay, I mean, if you walk into a primary healthcare center, you meet a doctor. Even some of these places have a medicine dispensing place called Niramai, and in these places you get the medicines and all also for free. On top of that, you have infrastructure from government like Jana Aushadhi and all, which are very, very affordable generic drugs, which government has created at distribution. So yeah, I mean, uh, though we spend a small part of our GDP into healthcare, and I think the recent budget has actually highlighted more spends into this domain. Uh, the government has actually done a fabulous job in trying to extend a lot of the services free. But the challenge is, if you reach a place and you don't have a doctor, how does the free service matter for you? I think we've done a fabulous job today on the Ayushman Bharat side.
What is that?
And Ayushman Bharat scheme typically is like an insurance scheme. It's a health insurance. You and I take a private health insurance, right? From a lot of the people in the socioeconomic class living in rural India, they're actually covered under the Ayushman Bharat scheme. So when they reach even a private hospital, and a lot of private hospitals are empaneled under this scheme, they get the entire tertiary up to a certain limit free because government pays the hospital, right? Uh, but again, as a country, you have made tertiary available to the socioeconomic class free, but nobody really wakes up in the morning and says, I want to go for a surgery, right? You have a discomfort, you meet a doctor, the doctor would advise you to take some medicine, get some tests done, and almost all these expenses are out of pocket. So the cost of care does not go down in some ways if you look at it, though your tertiary is taken care. And we don't have a scheme like NHS, which has which where everything is covered. So, but we made rapid strides. I think you can see the ABDM, the Ayushman Bharat digital mission, which is happening, which is just like Aadhaar. We are trying to create unique IDs so that data portability could be across facilities who are part of the ABDM certified platform, and you patients don't have to repeat the test. The same data can be used by doctors to sort of give recommendations and suggestions to what needs to be done next.
This Ayushman Bharat digital platform, I've been hearing about this for, I guess, 4 years now. I'm yet to experience it firsthand at any medical provider where I get some sort of an ID and I'm told that all your records are here and they're portable. In most cases, I still get paper, like printouts of reports, etc. What is the status on that?
It's a good observation, Akshay. I think as a country, we are moving towards digitization of a lot of healthcare records. But if you ask me, have we made significant progress there? I think it's work in progress. And what is unique about Aadhaar ID, which is the equivalent of Universal Health ID, vis-a-vis your Aadhaar ID is Aadhaar entire initiative was done by government themselves. If you see Aadhaar ID, government has actually partnered with private players. Like CureBay is a certified partner. People visiting my clinics, I can actually create Aadhaar IDs for them. Okay, so the government has taken a very different approach here. They're working with private players like us. We have to go through a certification process, but we can. create Aadhaar IDs for people walking in. You don't have to go to a government center only to create your Aadhaar ID. Once this is created, see, it's had to there are multiple ways in which it will happen. Your electronic health records of your personal healthcare records, which is what people are looking at creating in a place which is digitized and kept so that when you need that information, you're able to retrieve it easily and smartly. A lot of even startups and private players are creating PHRs which are now ABDM approved, right? NHA approved. So you can create your Aadhaar ID, your records can be stored, and that record can be moved across other platforms which are also certified, right? So uh, it's a mission, it's a project as a country for to do it for 1 to 1.3 billion people is not easy. But we have shown the world we have been able to do it for Aadhaar, and I'm pretty sure in the next few years you will see a lot of unique healthcare IDs existing in the country and people actually using EHR to retrieve their data.
Abha ID. So let's say I'm booking a like a health test from one of these apps, whatever Healthians or any of these. So I can put in an Abha ID there, and my test results will then be available there and portable.
It depends on the platform. If the
Okay.
platforms are certified, across certified platforms, there is a portability of data. Okay, but there are multiple private apps available today. If you use an app which is outside this certified ecosystem, okay, then you will still have your health records kept somewhere, but your data portability across other platforms will be a challenge.
Okay. 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 Got it. Got it. I guess there is incentive for everyone to avoid portability, right? I remember telecom companies had to be dragged into offering portability so, because you want high exit costs for the customer. Yeah. Okay. Got it. Okay. So now within this ecosystem, tell me what exactly is CureBay doing?
Let me give you a little bit of a context to CureBay. When I explained to you the topography of the healthcare ecosystem in the entire country, I told you about the urban and rural. And I also sort of highlighted how the infrastructure skew in rural has actually accentuated the problem a lot because 70% of your infrastructure is catering to 35% of the people, right? And this challenge is most seen when you come down to a primary healthcare level, where patients go there and don't find doctors, right? And this sort of is the first point of contact for a lot of rural patients. So what used to happen actually is when you go to a PHC, don't find a doctor, your next logical pit stop was typically a pharmacy. And pharmacy stores in India, the penetration is pretty good, right? And you go there expecting to, even we do it in urban India, right? We walk into a medicine store and say, "Hey, listen, I'm having a headache." The human nature, right? The danger in rural is this medicine stores a lot of times are not even run by a licensed pharmacist. These are run by somebody who's got access to capital in that rural market, right? He's got capital, he's opened a medicine store. There are ways and means to use a pharmacy license to get your drug license. When a patient walks in there, they behave like doctor and hand over a medicine. Now, what's wrong in that? What's wrong is 9 out of 10 times the medicine handed over is actually an antibiotic. The patient doesn't know about it, they don't have a prescription, so they don't have the course. As a result, rural India is dangerously becoming antibiotic resistant. That's the first sort of problem we identified. My logical mind started asking me questions. Why are they not just going to the district headquarter hospitals? Because they will get government infrastructure available with free services, and that's where you also find doctors. So why don't they just travel? And the initial hypothesis was probably the reason to avoid travel is commercial because two people will travel, right? A patient and a caregiver.
Yeah.
On top of that, it's not that they reach somebody's waiting to attend to them, right? They spend 2 or 3 days, so that's add to the cost of travel, this cost of staying. Most importantly, the cost gets amplified because unlike you and me, for them, every day invested in healthcare is a day of loss of income. So
Hmm.
they're constantly debating in their mind that, listen, 2 days of loss of income, right? So all this adds up to a huge commercial impact. And my hypothesis was this is the reason they're not avoiding the travel. But I was surprised when I came to know that while commercial is an important reason, that's not the main reason to avoid travel. The main reason to avoid travel was the experience. They reach there from bus stops, railway stations, even corridors of government hospital. They're approached by a very large informal network of what we call as healthcare dalals or brokers in India. These people understand their pain point and they have a
Right.
sharp eye. They know these people sleeping outside in the corridors of the government hospital are people who have traveled from rural India. They'll go and tell them, कितना दिन wait करेंगे यहाँ? आप चलिए, I'll take you to somebody where you'll get immediate medical attention, and they take them to places where they have an access, right? They end up going there, spending money, not getting the right service. And that experience is so broken a lot of the time you'll hear them telling you, "Gaon mein marenge, but we don't want to travel." Right? We're okay with that informal provider. And this we identified as a problem impacting 1 billion people in this country, and somebody had to do something about it. You just can't leave it saying public healthcare is government's problem to solve, right? And no new age innovative startup in healthcare was doing anything about rural. They were solving for you and me. We can get a medicine in 10 minutes at home. We can get a flebo, but that's not the challenge they were dwelling with, right? The supply chains of that urban models did not even exist in rural India. So that's where CureBay was born. So we took a very different approach. We created a hybrid model. So the part one of our model actually was a very robust tech platform that we built, which was designed on the principle of continuity of care. And we aggregated the physical healthcare ecosystem on this platform. So doctors, hospitals, labs, pharmacies, we all aggregated them on this platform. And we allowed them to collaborate real time to deliver health outcomes. To be very honest, this was the easiest part of our journey. The challenge was, how do you ensure these health outcomes reach those remote and medically underserved locations? And that's where the part two of our model came, where we opened a network of satellite clinics which were physical in nature called CureBay eClinics. Each of these clinics had physical presence of a pharmacist and nurse. They were extremely asset light and designed for assisted healthcare. And what we did in each of these centers, we provided them with three things. One was access to our platform so they could access all service and service providers. We gave them a few medical grade devices which they can use for capturing patients' data and vitals.
Like BP and fever and
Yes, BP, sugar, you can do an auscultation, all those can be, even a 12 lead ECG was provided there if required. And then we provided them with a few point of care tests. So all common tests required for rural India, like 70% of the tests are routine tests, right? Hemoglobin, lipid profile, sugar, HbA1s, could all be done there.
the machine was over there only to throw out a result. There was no need to send it to a collection center.
No. So like part of the all the routine tests, majority of the routine. Again, we operated in the principle of Pareto. We said, what are those 20% tests that we can do which covers 70% of the requirement? But we didn't stop there, Akshay, and that's a great question you asked. What about the tests that we could not do on the clinic? Right? So we trained our staffs to also be phlebotomists, which means they could draw blood sample, right? And every clinic of ours had a centrifuge. So we could draw the sample, we could centrifuge the sample, and then we created a rider network of our own, which could now come and collect the sample from there in ice box so that the sample is not spoiled, and then use multimodal transportation to bring it to a partner lab, where the sample gets analyzed. And post analysis, the partner lab uses our same tech platform. So real time, the report is available at my clinic. So I could either take a printout and give it to the person, or I could even push it to the WhatsApp. So in this way, what we did was we solved for almost 70-80% of the basic healthcare requirement, from doctor consultation, pre-consultation to medicine requirement to diagnostic at the center. But we didn't stop here. We realized that people will need, some of them will need tertiary intervention, and we don't do tertiary intervention, right?
One question: how does the doctor consultation happen? So you told me you have a nurse and a pharmacist there, and the nurse is also a phlebotomist, so he or she can draw blood, and you have some testing happening on premise. Some testing will go to a partner lab. I'm assuming pharmacy would be a tie-up with some player who would deliver pharmacies. Uh, what about the doctor consult?
So what we tried to do was we said we will not want the customer to use any technology. In fact, the patient journey at a CureBay clinic should be exactly same like an urban patient's journey to a polyclinic. So imagine the scenario: somebody walks into our clinic, they're greeted by our staff who are trained healthcare workers. They are then their vitals are measured. Okay, we ask them some basic questions to understand why they're there, and we triage the condition and create what is called as a clinical note, right? If you go to Apollo today or to any other large hospital, when you take an appointment to meet a doctor, before you meet the doctor, somebody attending the doctor meets you, right? They measure your height, blood sugar. This is exactly the same process which is done there. Then you're taken to a room to meet the doctor. The only difference is here the doctor is not available physically, but available digitally. 20% of the time, we actually ensure the doctor is physically available, but anytime you walk in, you'll meet a doctor, because if they're not physically available, they'll digitally be available. But this is where it becomes interesting. This is not a vanilla teleconsultation. The doctor, when they're digitally consulting with the patient, at the same time, our staff assist the doctor. For example, the doctor might need an auscultation to be done, especially rural patients. If you haven't put the stethoscope, you haven't seen them. So our staff puts the stethoscope, measures the blood pressure and all that, right? And because it's an integrated platform, the doctor is able to see all the values. And based on that, the doctor now delivers a prescription.
Like a digital stethoscope.
Yes, it's a digital stethoscope. Post this, all this data capture, the doctor seeing the data, doctor consulting with the patient, the doctor delivers a prescription which comes as a digital prescription.
Hmm.
And then, based on what is the advice the doctor has given based on that prescription, what is the next call to action, the medicines are supplied to the patient, the tests are done to the patient, and that's how you handle them through the patient journey.
Do you create an ABHA ID for everyone who comes in, or they have to ask you?
Yeah, we take their consent, we take their permission, and we tell them, listen, we can create your ABHA ID here, and those who give the consent, we do create their ABHA IDs.
What is the percentage of people who have an ABHA ID?
See, we got our certification about a couple of months back. So since then, we are trying to see that majority of the patients walking in to our clinic, we are getting an ABHA because it's free. So you just create an ABHA ID for everybody.
What is the incentive that you have to create an ABHA ID? Because it gives them easy exit from CureBay.
So one is the credibility itself, right? When you say that you're part of a government program and you're creating a government ID, there's a massive credibility that you get. But over and above that, government actually made it easier for private players like us because they gave monetary benefits. Okay, that scheme continued for some time, then they discontinued, it started again. So if you create ABHA ID, there's some amount which is paid. And as you add health records to those ABHA IDs, as you enrich those ABHA IDs, you're paid some additional money. This is not a permanent scheme, it's a temporary scheme. It's like it's like an accelerator program to, sort of get the private players to do this.
You have that initial primary consult there, but that wouldn't cover all cases, right? So, what happens when someone needs more serious intervention?
Yeah, if somebody needs, if our doctor, so imagine how the process happens, right? The doctor does a consultation. Typically, when the doctor is consulting with you, the first consultation is like a prognosis. The doctor forms a hypothesis about you, right? Then they ask you to have medicines, then they ask you to get tests, which is nothing but collecting more data about you. And this data helps the doctor convert the prognosis into a diagnosis, and that's how they put you on a care protocol, right? Now, if during this process the doctor understands that you need a tertiary intervention, some of your test results are clearly indicating towards that, they'll refer you for a tertiary intervention. What we do then, there are two things that happen. You might be referred to a specialist, in which case we immediately arrange for a specialist consultation for the patient in rural India right there. Only thing is we take 24 to 48 hours.
Online or
It's online. It's online. So we get them to speak to a endocrinologist, a nephrologist, a cardiologist, whatever they're referred to. Okay. But again, we ensure that they don't have to travel, they don't have to worry. Imagine meeting a super specialist of a very large hospital sitting right at your village, especially when your case history is already known to him because you have been examined and your records have been shared. So you're sort of transforming the experience which they have not done. Now, post the specialist intervention, or even if there are early cases where even the GP would recommend that you're a confirmed case of appendicitis, you should go to a hospital and get the appendix removed. We very transparently tell them who are the partner hospitals on our network. By the way, which partner hospitals are covered under the government scheme? Because a lot of these people have the government scheme, right? So they would like
like
to know that.
Ayushman Bharat?
Ayushman Bharat,
Okay.
yes. So you have to understand, Akshay, in healthcare in India is a state subject. So Ayushman Bharat is a national scheme, but there are some states which run their own scheme. Like Odisha used to earlier have a BSKY scheme because we had a different government at the state, right? But today we have an improvised version of the Ayushman Bharat scheme here called Gopabandhu scheme. So every state will have some other scheme, either a version of Ayushman Bharat or their own scheme, right? Now, you give people that transparency, which hospitals have that. Most importantly, what you do, you pre-schedule a date for them to go when the doctor is available, rooms are available. And I'll tell you why this is important. Because when they go there, there's somebody from CureBay available just like a family doctor. It's a concierge service that we offer them to take them to a partner hospital to get their paperwork done, get them admitted. Now, this is really transformative because what used to happen earlier, even if they knew there's a government private hospital under the government scheme, when they reach there, a lot of the time the hospital tell them the bed is not available. Your sugar is pretty high. You need to have this medication. Come back. So there used to be multiple trips. And refer to my earlier point. For these people, a day invested in healthcare is a day of loss of income. So when you make them travel multiple times, you're actually not just increasing the cost of care, you're making the experience very broken for them. And here, sitting at their village, it's fixed for them. They go there, somebody has to receive them, get them admitted so that they get the intervention and come back. And they don't pay anything because the hospital is paid directly by the government. So that's how we sort of complete the circle for them.
Interesting. I want to talk a little bit about money. What does one center cost you? Like, do you pay rent there, and what are the salaries there typically? What's like a monthly outlay?
In these deep rural markets, we have no intention of owning real estate. So we go and find a property which is suitable for a clinic. We take it on rental basis. Typically, the operating expenses of a clinic, depending on the location we are, would range between, say, on the lower side, 35,000 to on the higher side, 55,000. So that would be the range between 35 to 55,000, including rent, including the salary that we pay to the two people, certified home healthcare workers that we have there.
What are the revenue sources for a center?
So we have two sources of revenue. One is transactional revenue. So whether you do a consultation, whether you get a diagnostic test done, whether you buy medicine from us, whether you go for a surgical referral through us, all these are paid services. So in some cases, the patient directly pays us. Like if you're doing a consultation, you pay from your pocket. If you're buying a medicine, you pay. And if you're going for a surgery under the government scheme, the hospital gives us partnership fee that we have with them. But all these are transactional. We also have a very, very interesting program, Akshay, and I would like to talk about it. It's called Kavach. And this, in my view, is truly revolutionizing how healthcare is getting consumed in rural India. And I think this is the biggest differentiator for CureBay. And I have to give you a little bit of context to this, right? I mean, people in rural India seek healthcare in a very different manner compared to you and me. If something happens to us, if we have a healthcare concern, we are privileged lot. Our family, our friends, our peer group, everybody will take us, listen, take a day off. First priority is health. Go and meet the doctor. For them, it's a constant debate. How long can I procrastinate and delay? Because they know it's going to cause loss of income for them. So typically, a lot of the time when you're actually meeting the patient, you're meeting them at a time when the condition has become acute or chronic. Okay, and they need immediate intervention. So when I was trying to build CureBay, one of the thoughts that was always playing in my mind is how do you ensure that you're able to move people onto a preventive journey? This is something which we have not even achieved in urban, to be very, I mean, I was mindful of the fact that even developed countries, even urban India has not done. But I was very clear that, if I'm solving for rural, I want people to move in that direction. So we created this program called Kavach. It's a membership program. So actually for 499 rupees a year, okay, we give them throughout the year free healthcare services, doctor consultation. We give them free, a few limited number of specialist consultations. But what makes it really interesting is it's a holistic healthcare solution. So for the amount that they pay, for 99 rupees, we actually return them 1,000 rupees as CureBay coins. And they can use these coins to buy medicines or get tests done at my clinic. First. Second, I told you earlier that, a lot of them are covered under the Ayushman Bharat scheme when they go for a tertiary requirement. But there's a lot of out-of-pocket expenses before the tertiary requirement, right? So we've created a program which sits very well. So we pay them 500 rupees per day for the number of days they're admitted in the hospital. So typical, these are elective surgery, 3 or 4 days they'll be admitted. They'll get 2,000 rupees,
Hmm.
which covers their out-of-pocket expenses, travel, a companion accompanying them. And lastly, we realized if you have to meaningfully solve healthcare, you not just have to solve about the health issues, you have to solve one of the biggest issue for them, which is a financial issue. Because when there's a health emergency, these segments don't belong to a formal segment, right? They don't have bureau scores and all. So where do they get the money? In case of an emergency, they rush to these local money lenders. The interest rate in some cases varies from 5% to even 10% a month, right? Imagine you're taking a lakh of loan and literally paying between 60,000 rupees a lakh to service the loan. You will never come out of debt trap. And that sort of pushes a lot of people below the poverty line. So what we do, we tell them in case of an emergency, because we're a healthcare system, we can scrutinize that you're a genuine case. We'll refer you to a partner hospital of ours. If there is an emergency and if your limits have gone outside what government has already provided you, we will give you that loan directly to the hospital so that there is no misuse. You pay back without interest. So it's an interest-free loan that we offer to them. Interestingly, we have done all this with partnerships with various players in the ecosystem. But the package that we offer to them at 499 comprehensively takes care of their healthcare requirements, their financial requirements, their out-of-pocket expenses, everything. And the reason we also did this was we said once you create such programs and get people onto this program, you then engage with them. Like you call and tell them, hey, okay, you have free consultations, right? If there is a concern, don't wait till the condition is acute. And you will not even miss a day because I'm right there at your village. Come to the clinic, meet a doctor. Whatever the doctor asks can be done here. After 15 minutes, you go back to the work. So there is a financial incentive as well. There's an incentive of, staying healthy and not having to lose a days of job and all. And this way you sort of also pick longitudinal data about people and ensure that you're able to monitor, keep them healthy. That's the dream. That's the vision. We already have close to 130, 140,000 people on this membership program. And I think in some way we're revolutionizing how people are consuming healthcare in rural India.
See, this sounds too good to be true. I don't see how you will. I mean, is this a lost leader for you? Like,
No, it is not. Very, very interestingly, I must tell you. This question has been asked to me before because exactly the reaction is exactly that. This is too good to be true, right? 500 ruपया ले रहे हो 1000 रुपया दे रहे हो, how is it possible? This is actually the whole product has actually been designed on the same principle that insurance products are designed. It's an actuarial science. So you take an assumption of how many people will engage, and then you create some sort of checks and balances in the process so that it's not misused. For example, when you need medicine, you will get the medicine free, but you need to consult a doctor because even the right thing in healthcare is you should get a medicine only with a doctor prescription,
hmm.
right? So we say your consultation is free. So we'll enable you to have a doctor consultation, get a prescription. So we give you the right medicines. Okay. And we sort of manage the structure that there is no misuse and there is a way we sort of price it to ensure that we are still in the money and not out of money there. Similarly, we do for diagnostics. For the insurance cover that we give them, we actually do a back-to-back insurance for every customer, but not every customer avails of the facility. So your loss ratios are actually pretty low.
By insurance cover, you're referring to that 500 rupee per day.
The 500 rupees, yeah, it's like a hospicash. Okay, so under a master service agreement, we do that, and we have back-to-back covered our risk with the insurance partner. For the last part, where the interest-free loan they get, it's not interest-free actually. So CureBay subvents the loan, right? So we subvent the cost of the loan because we have a referral fee from the hospital. So we leverage that to subvent the loan so that the patient doesn't feel the pinch.
I believe there was a company which was doing something similar to this. Maybe it was called Kenko. Have you heard of them? Although I think
Yeah,
they might be a
it was
more,
an urban phenomena. And
yeah.
actually, a lot of the schemes that I've studied, actually, people were charging what we charge for the year even higher than that per month. But obviously, they were looking at a very different kind of audience, urban audience, and not to do that. But I don't think the program succeeds just by creating a product. The program succeeds by creating a manner in which you're not just making a promise, you're able to fulfill the promise. Now just see what happens in Cure-based context and why an insurance company has probably more money than me. Why are they not doing it? You might make that promise that you can have free doctor consultation, you'll get that. Where will the patient get it? They can't get it at a government facility. If to get that they have to travel all the way to the city, they'll throw that program, right? Here, not just we have created a very powerful solution for them, we're saying the entire promise get fulfilled at your doorstep, walk into the CureBay clinic, which is right here. That model of making a solution, which is very powerful, and then ensuring the fulfillment of that promise happens at their doorstep, is what makes this product. I would say that's a secret sauce in this program.
What does the P&L look like for, let's say, if you have 100,000 people who buy this product? What would the P&L look like there? Like,
Mm,
would it be
elaborate on what aspect of the P&L
profitable?
you.
Like,
Yeah,
would you
of
make
course.
money over a hundred
See, no,
thousand
no, we
population?
do because see, for me, the cost of CAC is very low because I'm not into digital acquisition spending like wild, spending more than what I earn. My people come through the catchment area of my clinics through the Swasthya Mitras that we have. So the CAC for me is very, very low, and this product sort of, uh, you're getting money in advance and you're delivering services through the year. So it's a very, very interesting product. I wouldn't like to go into details because this is sort of a differentiated product for us. But it's a good P&L to have.
And how recent is this product?
So we had an avatar of this product, not as powerful as what I spoke to you about a year and a half back. But in the new avatar where we got it comprehensively done, it's about 6 months old.
Okay. So too early to look at churn rates, retention rates, things like that.
No, interestingly, a lot of because the earlier program was over a year, so people who have
Mm.
come back for when that program has expired, almost 60% of them have actually renewed the program based on the new program.
Okay. Okay. Okay.
So very,
Okay.
very strong early signs of people renewing the program.
Okay, okay, okay. Interesting. Now, in this whole thing, the one piece we didn't talk about is doctors. How, like, you haven't told me how, what the doctor. So you told me 55,000 is the cost of a clinic, but that doesn't include the doctor
That's
cost,
a
right?
that's a OpEx cost. No, that's not.
Right.
So doctors operate with me in a very different model.
Hmm.
I have two sets of doctors. The first set of doctors is what I call as empanel doctors with me. These are doctors who are on a fixed time, on a fixed payout model with me. What I do is I use the tech platform for smart rostering of these doctors. So I have slots when they will be active on my platform. What that allows me to do, Akshay, is anytime to stay true to the promise that anytime you walk into a CureBay clinic, you meet a doctor. There is no waiting time for you. By the time your vitals and all are measured, you're taken to the room. There's a doctor live to meet you, right? That part, and these are mostly GPs, so general practitioners. I price that consultation. If you're part of the membership program, obviously it's free, but if you're not, it's 100 rupees. Okay, yeah, and you pay 100 rupees and meet the doctor anytime. But then also spoke about doctors that are super specialists or specialists that you're referred to, right, through these GPs. Now, those doctors work on a model which is an inventory model with us. So those doctors, we have tie-up with certain doctors who tell me what time slots are available with a 24 to 48 hours advance notice. So when a patient needs to meet a specialist, I pre-book those free slots with them and then get the patient to meet. There we act on a revenue sharing model. There is no fixed payout for me. What there is a revenue sharing between me and the doctor.
Okay, okay. These GPs are like on your payroll.
We don't call you never have doctors in your payroll, so you call them as empaneled doctors of
Empanel.
yours.
Okay. Hmm. Got it. Got it. Do they sit out of a central place which you provide, or how does
No, so the beauty of this model is, and we actually found a little bit of a Goldilocks zone here. Doctors never retire. My mom's a doctor. She started one of the first private nursing homes, and I've grown up in a house of doctors. So I've seen that doctors never retire. So a lot of these government doctors who had retired, we went and approached them and told them, listen, now you can practice from your home. You can still stay in touch with your patients. We will enable you to consult with the doctors digitally from wherever you are. Initially, there was a little bit of hesitation and inhibition to use technology. But then, I always thank Meta because the line I use is, have you used WhatsApp? 9.5 out of 10, not even nine people will say yes, right? And then you say, this is as simple as WhatsApp. I'll enable you to how to use it. So doctors sit from their home. There are time slots. They know these are the time slots. I need to be active. It's a very sophisticated doctor app we provide to all these people, and through that they consult.
okay, okay. How big is your team? In-house
Overall,
team? Yeah.
The CureBay team, our
Yeah.
doctors,
CureBay team. Yeah.
we are close to I think 900 people now.
Oh, wow. What's the split? How many people in what
See,
functions?
every clinic has two staff, right? So today we are close
Hmm.
to 200 clinics. So that clinical staff itself is close to 50% of this time.
Right,
And
right.
then we have over 100 people. We are a tech company. So we have a very, very strong tech team. We have a specialized AI team. Then we have people in operations, sales, and all the other supporting functions.
How does sales happen?
I think the biggest method of sales for me is this whole network of Swasthya Mitras that we create. So I think I need to speak a little bit about that. So when we opened clinic, we realized that there are two sort of barriers that one has to overcome. One was rural patients were sick and tired of urban experiments. When I initially went and spoke to them, they told me, a lot of these camps happen, mobile vehicles come. We go there because we get free breakfast. We eat the food. On our way back, we throw the medicine. And I was curious to say, why do you throw the medicine? They said, because they come at their convenience and do these camps. When I need healthcare, who's there? So the first parameter to establish trust was that I am there when you need me. So hence the CureBay clinics came into play, that we opened the clinic. But we realized that's not sufficient. Um, Initially, I thought, Akshay, I'll open a clinic and there'll be a queue outside because there was no healthcare facilities. I've got you such an amazing clinic, but it doesn't happen because people will try the doodh haldi at home till they build the trust and credibility because CureBay was still an alien in that space, right? So we And the catchment area of a clinic typically we define as a 0 to 10 kilometer radius. That's maximum that somebody will come to your clinic. So we identified highly credible people. These were retired school teachers. These were people who were working with NGOs, self-help group. Even some of them were people who were associated with medical profession but had retired, or even a pharmacy store who had a lot clientele base but wanted to do other services. So we trained them and made them Swasthya Mitras. The Swasthya Mitras represented CureBay in their community. And the amazing thing we did was we created an app for them called Engage. This app sat on the mobile of my Swasthya Mitras and extended all the services of the clinic onto their mobile. Now, these were people who had tribal knowledge of the community. They knew who's expecting a baby, they knew who's fallen sick, who's broken their leg. So they went to them and told them, hey, listen, you don't have to worry. You don't have to worry even about using technology. I will facilitate a consultation for you. I can order medicines for you. I can get somebody from the CureBay clinic to come and get your test done here. So they extended our services into the household of people, and that's how slowly we started building trust and credibility with the community. Because the principle was rural healthcare is not just clinical healthcare or processes or technology; it's community healthcare. So you need to get the community along with you.
Mm. Okay, okay, okay. Uh, These are like on payroll, or is this a
No,
voluntary system, or what?
this is like a gig workforce for us, right? These are
Okay.
people who sort of invest a few hours in the week, and obviously they
Mm.
get remunerated based on their efforts.
Okay, okay. Like number of sign-ups that they
Yeah, yeah,
organize,
yeah,
something like that.
absolutely.
Okay,
And
okay.
everything is on the platform. There is no intermediary. Everything happens real time. We are pretty tech savvy, so there's a neo banking account, so
Hmm.
instant sort of getting the value onto your wallet.
Do you have competition? Are there other people building this sort of a remote consult uh, kind of a model for rural India?
I want to ensure that there's humility in my answer. I don't want to sound as if I'm doing something which nobody does, but Akshay, I've tried hard to find out a similar model. And when I say similar model, somebody who's bringing full stack healthcare, not just teleconsultation, is a commercial model, not backed by some CSR fund or a grant, and is scaling up to the extent we have done and meaningfully solve customers. I have seen none. And I think that's the reason we are generating a lot of interest, a lot of partnerships. Requests are coming because I think this is a pretty unique model. And even in some international forums, I've been approached saying this is a model that you're doing, which has a same use case in places like Africa, Latin America, Southeast Asia, and all, because all of them are dealing with the same problem of scarcity of doctors to patients ratio.
Is this because it's an investor blind spot? Like maybe VCs don't feel like serving healthcare needs, primary healthcare needs of rural India is profitable. Therefore, there's no competition. Or
No, I won't agree that. I mean, I have some of the best VCs on my cap table. I have Elevar, which is very high on impact. I have Bertelsmann, which is one of the marquee commercial VCs. I even have a sovereign fund, which is British International Investment on my cap table. So if this was a blind spot, then you won't attract, the nature of and the quality of VCs I spoke about. I think it was more of a lack of a precedence. Everybody wants to play safe. If you're the first one who's doing something which is market defining, people wait and watch, right? And the second thing is a lot of people operated under the urban myth that rural India doesn't pay. Rural India seeks free healthcare, and I think CureBay is proving it wrong.
what is the role of understanding, leveraging government ecosystems in building CureBay in reaching to where you have reached so far?
No, absolutely. I think eventually what we are doing is we are an adjacency to the government's effort. Right? Anything that you want to build at scale in this country, I don't think any private player can do other than government. So you need to figure out, how you're complementing and extending and not sort of building or replicating a process. For example, when you look at our Kavach program, it sits so beautifully to take care of the out-of-pocket expenses before somebody gets the benefit of Ayushman Bharat. A lot of the Ayushman Bharat facilities had private hospitals, and the lack of primary, you always used to clog the tertiary. The load at the tertiary hospitals used to increase. Now we do a screening. We actually break the load by giving them primary intervention and just ensuring the right people are going for the tertiary care. So somewhere we are ensuring that the exchequer, the money that is being spent by the exchequer is spent at the right places and people are getting the right benefit, and the healthcare system is not getting choked. So yeah, I mean, it goes without saying that you got to work with government in some initiatives like this. But we operate completely independently. We don't have a direct interaction with the government as of now. Some interesting experiments are happening, but yeah, we operate like an independent venture-backed company.
Okay, okay. So this is not your first rodeo, right? Tell me about tell me about how you got here, like a little bit of your career
Ah,
journey and
okay. Okay, so actually, if you see, what did I do before CureBay? I was with Google. I was part of the India cloud leadership business, trying to build the cloud business of Google in India, a consumer company getting into the enterprise space. Before that, I was with Microsoft, and I was responsible for building their consumer business. So Microsoft was an enterprise company where I was building the consumer business, and I used to joke with everybody that they pay me for playing games because Xbox was part of my portfolio,
yeah.
right? Before that, I was the managing director for Avaya for Southeast Asia. I set up the mid-market business for SAP in India. I set up the retail practice, telecom, the telecom, yeah, it's gas company. And before that, I set up the retail practice for Sun Microsystems in India. But I always say this was part two of my life. Some interesting projects with a lot of big tech names. Part one actually had nothing to do with tech. I was a consumer person. I was part of the team that launched a brand which has become significantly large in India today called Tanishq. So the whole positioning of Tanishq on the Purity platform, the carrot meter, there were a few of us who were involved in that project. So after the success of Tanishq, all six of us quit. Early days of VC funding in India, 99, 2000, and everybody was doing something in .com. We opened a retail chain for branded jewelry called Oyster Bay. So that was my first startup. Much ahead of time before you saw the CaratLanes, the Blue Stones of the world. We went on to become the second largest branded jewelry chain. Exited in 2006 when Fossil, the American watch guys, acquired the brand and Rajesh Mehta acquired the distribution. Purely by accident, I came to the tech side of the world and interestingly stayed there.
Tell me a little bit more on Oyster Bay. Like, how many cities, how many retail outlets had you opened by 2006?
We were with our exclusive shops as well as the shop-in-shop network. We had 50 plus retail points at that point, and we were present in. So those are the days which were even before the mall culture came in, right? So if you were really defining retail those days, you had to be in the high street. And you name a prominent high street in India, we were there. From the linking roads to the Park streets to the CP to the GK, MG roads, everywhere there was an Oyster Bay showroom.
This would be like, say, a PC jeweler kind of a competitor.
No, we're very different. We
Mm,
realized the niche that we sort of went after that time was we said a lot of the jewelry that was being bought in the country was bought as part of your wedding trousseau.
mm.
This is my heavy, bulky jewelry. And also in India, we buy the yellow metal as a something that
Investment.
stays in the
Yeah.
locker, right? It's an investment
Savings.
for a
Yeah.
rainy day.
Yeah. Yeah.
Now, we wanted to create a category. It was a completely new category, which is jewelry for the modern working women. Something that the modern working women will be comfortable wearing it and going to the office. So we actually called it jewelry for the living. So
Mm,
the idea was every other jewelry is dead and locked
mm,
somewhere, but this is
mm,
jewelry that people wear. So the tagline was Oyster Bay jewelry for the living.
mm,
We were ahead of our times, I think. The biggest success I say in retail is when demand exceeds supply.
mm.
And we did encounter that situation. We realized that this requires very heavy, probably private equity kind of investment, and hence exited. Maybe should have stayed a little bit longer, could have taken it public,
Yeah,
but
exactly.
nobody sees
Exactly.
the future.
Mm, 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 mm. Okay, okay. And what was the top line when you sold for
A
Oyster Bay?
long, long back, but I think we were pretty close to 100 crore brand at that time.
Wow, which is pretty good for, I mean,
Yeah.
at that stage. Okay, okay, interesting. So, and after the sale, why did you go into tech? Like, so then you joined SAP.
Oh, no. So this is a very interesting story. So actually, after the exit happened, I was pretty clear I want to take a break, a sabbatical, and come and start my next startup. So I had an admission in INSEAD and Wharton, and I had decided to join INSEAD because INSEAD was 1 year, and I said I'll go to Fontainebleau, then do a few semesters in Singapore. They had a tie with Wharton, so I'll do 1 term in Wharton, completely network, then come and start my next venture. And at that juncture, I met somebody who's been my mentor and guide ever since then, Mr. Bhaskar Pramanik, who's also the chairman of my board today. He was the head of Sun Microsystems. we had a conversation which changed my sort of decision making. And I said, let me go into a new world. I considered him my first VC after my exit, saying, okay, here I'm getting paid to try something to build a retail practice for Sun in India. And from then on, I think I saw success one after the other and continued in the tech world till COVID happened. Till COVID happened, and all of us got into a complete lockdown mode. I had a bit of a health issue at home. My wife actually needed attention, and I was wondering what to do because we were all like literally we could only step onto the balcony to hit those plates with the spoon. Domestic guards were security guards were not coming home. Domestic help was not coming in. This was the first phase, right? Complete lockdown. I didn't know what to do, and I tried to reach out to a private hospital. An appointment was fixed through the corporate types that we had, and somebody asked me for my Skype ID. And I burst out laughing. I said, "Listen, I used to head Microsoft's consumer business. Skype was a product. I don't have a Skype ID. So who's using Skype in today's day and age?" And that sort of triggered so many thoughts in my mind, and that's when one thought led to the other, and started working on my thesis. And CureBay was born.
Uh, for founders who are transitioning into corporate roles, and like you did a pretty hard pivot there from complete startup to a like a legacy corporate, what advice do you have? Like, and you succeeded in that corporate stint as well, so what.
When we exited from Oyster Bay and I was getting to corporate again in Sun, a lot of people told me, listen, you've been a founder, how will you now sort of work there? And to be honest, I think it's such a non-issue because if your entrepreneurship is not just about starting your company, I think it's a mindset. And when I joined son, Bhaskar, told me one thing. He says, I'm hiring you because you're an entrepreneur. We don't have a practice, build it. So for me, it was again doing something completely new, building something. And I think that's the strength. Entrepreneurs see opportunity where others see a challenge. And again, the same thing. When I went from Sun to SAP, mid-market was a very small business for them, right? And they wanted somebody to build the mid-market. And when I exited, the mid-market business was bigger than the enterprise business. And when I went to Avaya, Avaya had been just taken private by TPG and Silver Lake, and they had acquired Nortel. With the acquisition had not gone the right way, and they were looking at a leadership for turnaround. So I joined Avaya for turnaround. I already told you about Microsoft. I joined an enterprise company to head the consumer business, and we grew it here. So I believe that if you have that mindset, you will find entrepreneurial opportunities even in corporates. And if you're a true entrepreneur, you'll build new businesses, you'll turn around businesses, you'll take it to a different level and enjoy, and you'll get the same kind of fulfillment and kick. Maybe in one place you have equity, the other place you have RSUs. That's the only difference.
You've scaled up CureBay pretty fast. You started in 21. I think you've raised almost close to $40 million till date. 35 million till date. 200 clinics so far. Um, what what are those principles which you would have learned over your 2-decade career, which helped you to scale at this pace and this speed?
I think one guiding principle for me has been execution first. Ideas are dime a dozen. Not that people did not know that rural healthcare is a gap. Everybody knew. Uh, Everybody probably at some point would have thought how to solve it, what to solve it, and then created their own hypothesis, dropped the idea. Uh, for me, my learning has been, listen, if there is an opportunity, jump into it, execute it. The execution itself will teach you. And I think this principle has been also influenced a lot in some of the corporates that I've worked, where we spoke about growth mindset, learner's mindset, that every day you got to approach the work, that you got to learn something. So I've been very, I would say, audacious in terms of trying new things. I've picked it up from my corporate days.
MVP approach that startups talk about, like
I
build an
I
MVP.
I I don't even call it an MVP approach. I said just go all out.
Hmm.
Put your heart and mind to it. Because the
So
moment you
what's an
say something
example of
like an
this?
MVP, you are sort of trying to mitigate risk. You're
Hmm.
de-risking yourself. If you're
Hmm.
a true entrepreneur, you believe in the idea, don't think about de-risking. Make sure it works. Make sure it happens. And I'll give you an example when we were opening the clinics
How much into the journey did you open your first clinic? Like, did you think you'll do digital only and learned clinic later, or
8 months. No, no. The model from day one, what we thought is exactly what we're operating today, hybrid. There are some very interesting adjacencies which have now developed on our data play, on our tech play. That's beside the point, but the core hybrid approach was there from day one. So when I started working on the idea, I was working towards opening my first clinic, and it took me what, about 6 months, 7 months to open the first clinic. Okay, and again, you know, I was actually advised to do a lot of market research, do price testing, do demand discovery and all that. And I said, listen, the best way to do it is open a clinic. You believe in the idea, open it because you're going to continue in it. So every time something doesn't work, you'll figure out a way to make it work and go to the next one. And that sort of has been the mantra that I've always told. The other thing I've followed throughout my corporate learning, which I even embraced today, and my teams started making fun of me, is I always trade in favor of speed. You cannot deliberate, intellectualize a problem to the extent that you're losing time. Okay, it's good to take views, but there has to be a captain of the ship. You're not running a political party here. You have to take decisions, move ahead. And you trade in favor of speed and go ahead, execute. Because the best learning comes when you try, it doesn't work, you fail, you pick up the nuances and move forward.
Uh, Clinic one, how did you decide where to open it, and the
So now you've caught me on my weak spot. So initially, for all the training, formal training I had in terms of relying on data, what to do, I actually went by my gut. And initially, I was completely over sort of, I was possessed with the idea that I have to go to places where no healthcare is reached. And I went really remote. I went so remote that even patients didn't exist. Right? So I told myself, listen, one has to be practical about it. You got to go to an area where you have a basic critical mass. There's a catchment, there is a density. So instead of, and the other learning for me was when you go very deep inside a village, you're seen as that village clinic. Even the patient from the next village will not come. So you have to find nodal points. Typically, you see these village hearts happen. They happen in nodal points so that people from the adjoining villages also come for shopping. If you go deep into a village, you are that village phenomena. Okay. So we moved away from the blocks and taluks, but we started targeting those nodal points, those places which had a decent catchment, so that commercial viability could be done. So the first clinic, did I sort of do a brilliant job in selecting the location? Absolutely not. But I think we did a brilliant job in terms of the speed of execution and learning fast that you got to be practical about some of these things.
So that clinic is no longer there. That
No, it's
location.
still there.
Oh, it's
It's
still
still
there.
functional.
Okay,
Yeah, it's
okay,
still functional.
okay, okay. Interesting.
But 5 to 10% of our clinics we have gone wrong. Not with the first clinic, but even there in the early days we have gone wrong, and we have gone wrong not just because of the location. We have gone wrong for multiple reasons. Somewhere we initially went with a franchising model, so we looked at a local person to sort of run again based on the same model of trust and credibility, and then we realized that in healthcare you got to be very very careful on ensuring the trust infrastructure that you're setting up. So the delivery has to be in your control, and some of the changes we made on the way.
Okay. And when did you raise your first round? Was it after the clinic got opened, or?
Yeah, I reached 22 October,
Okay.
about what, 7, 8 months after my first clinic opened. By then, I had 8 or 9 clinics.
Ah, so that was all self-finance. The that
Yeah,
journey.
so I put in my own money, my co-founders put in money, and
Mm,
we had a very, very interesting round with friends and families.
mm.
In fact, I had like 22 CEOs of India join my friends and families round,
Wow. Okay.
and we had decent amount of money. We raised over 1 million in our friends and family round, and that sort of funded the initial journey.
Oh, what was the pitch to a typical VC? So one is an impact VC, like say LUR would obviously be seeking out opportunities like CureBay, but for a more traditional kind of a VC, what's the pitch to them? Like this 21 million round you raised last year.
I truly believe a good VC, even an impact VC, LFI, is very, very commercially focused. I think the returns that you see a good impact VC makes is better than commercial VC. So I was very clear. There is no two different kinds of pitch. The pitch is very clear. This is the audience. Okay, so the audience that we are going after is rural audience. We are looking at 1 billion people's problem that we are solving through an hybrid approach, and we are solving in a commercially viable model. We are not doing something which is for charity. We are not doing something which is forever, wait forever for something to happen because you are impacting a lot of people's life. We will return. It's a non-trivial problem. To solve this, I require non-trivial money. And to get non-trivial money, I have to show people that they make money. to attract more capital to come in. So that was the story was consistent for all the VCs. It's just that at what time who came in.
Uh, what's your moat? And forgive me for saying this, but in this podcast, you pretty much explained your business model. Somebody listening to this podcast could say, okay, I'll impanel doctors and I will go and open clinics in rural India. You've got 200, so which means there's probably scope for 2,000 such clinics. So you're probably at just 10% of the opportunity at this stage. What's your moat?
I honestly believe, and actually, this is coming straight from the heart. If somebody wants to copy my model, I'll welcome that entrepreneur to come sit with me and give them every bit of my learning because I believe there are 100 CureBays required to solve this problem for a billion people. I'm in Odisha, Chhattisgarh, Jharkhand. In the foreseeable future, I'll be in Bihar, Madhya Pradesh, Telangana, Andhra, Eastern UP. I would have just scratched the surface. So, if this model can become a legacy that I create, and there are other founders who can take and solve in different parts, which I can't reach in the time that I see, I will believe that's how success should look for CureBay, not just what I'm achieving at CureBay. And that's the reason I'm absolutely not hesitant about discussing any part of the model.
Okay, amazing, amazing. You said you discovered opportunities in data and tech later on. What are those opportunities you've discovered?
We try, if you look at it, we tried to solve a very hard problem. We were trying to solve for rural healthcare, and you realize not everything can be physically made available. So you need to rely on tech. Also, for screening people, you need to develop models. And some of these models were AI models because you could not create very expensive devices to go and screen people, right? And in real sense, the strength that CureBay had was we were collecting very compliant real-time data from the ground because we had like a clinic network where for 200 clinic, you're talking about 400 trained healthcare workers. On top of that, add the 1,000 Swasthya Mitras. So you had a very strong sort of, I would say, army on the ground to collect data. Now I realize a lot of the people, a lot of the startups are creating these AI models in healthcare because it's become very fashionable and raise money. And I came from the world where Google or Microsoft could give you an API for you to create a smart model, right? 96% of this was trained on synthetic data. You cannot rely on that to make any kind of prediction in something as sensitive as healthcare. The true meaning of a model is which is trained on real data. That's what we are doing. We have developed 6 or 7 AI models which we are training with real data. We don't talk too much about it, but a year or two down the line, these will probably be far more accurate in terms of the prediction, the way they're getting trained today. And the reason I say I discovered it because we were approached by people saying, "Can we get data to train the models?" And I realized, listen, I have the data, I have the ability to create the model. Why not build? Second discovery for us has been we created this real-time, fully integrated platform, right? From tertiary to primary to my network on the ground to now everything is connected. I don't think a model like this existed because the large hospitals which had the money did not have the need to create some model. They really, in terms of technology, what they used was a hospital information management system, right? Everybody else was doing it physically, not doing it. So the model that we have created today is something which I think the country needs. If you have physical infrastructure in place, you have shortage of doctors, you want to connect all your primary centers with tertiary, which is where the doctors are available. So connect the demand points with where supply is available. You need a platform like this. So some very interesting conversations are happening on leveraging our platform.
But I don't think there are any players who do both primary and tertiary, right? I mean, tertiary
No,
is a separate set
nobody
of
does, but
players, and
yeah, so the way this is going to evolve is it's an ecosystem play.
hmm.
The ecosystem would like to be connected because people are doing bits of it. And for them to get connected, they need a platform like this.
So this would be like a Practo, like a standalone SaaS that you're seeing it, or are you selling it as a white labeled solution?
No, we will probably, I mean, it's too early to comment on that, but I think the
Hmm.
power of the platform and the conversation we are having is it could be a pure tech SaaS model that we can take into the market.
Okay, okay, okay. I want to zoom in a little bit more on AI. This is what I imagine when you tell me you are creating healthcare AI models. Like, say, a model uh, hears the stethoscope output and sees the BP and the temperature and a couple of such data points, and on the basis of that, predicts a 90% probability that this patient has pneumonia. Is that the way a model
That's
works?
one.
Or
There's
okay.
one use case. This is not the exact model CureBay has, but we have some very simple model, I'll tell you. The markets that we operate, for example, we operate a lot on the coastal belt because we started in Orissa, right? Skin is a problem, dermatology is a problem, and availability of dermatologist is an issue. So we have a very smart AI where you take picture of your skin, upload it, the AI will tell you if. So what we do, we use the model to stratification of risk. So if you are risk stratified as a high risk person, then we immediately tell you now connect with the CureBay clinic and we can get a doctor dermatologist to see. So we close the loop. So we first use the AI model for risk stratification screening, and then the high risk people we connect with professionals who will give you the right medical advice to close the loop. So there's no point scaring somebody with an AI model and then leaving them high and dry, right? Exactly the same thing we do for dental. A lot of people chew bitter nut there and they have dental issues. So we tell them just take very easy, take 2 or 3 pictures, upload it. And even we don't expect the end customers to do it. So we give a lot of this product to our Swasthamitras. So my Swastha Mitra knows you, they're having a conversation, they'll tell you, Akshay, let me take 3 pictures. Within a few seconds, you will get a report on your WhatsApp, which shows the condition, and then it says, listen, looks like you're great, doing great, no worry. Or listen, looks like you need a few interventions. Why don't you walk into the cubic clinic? We'll get a dentist to speak to you. That's how we sort of connect the AI model. That was our idea, right? We said in healthcare, a lot of ecosystems exist in silo. For example, there's a medtech ecosystem. Amazing work is happening on the medtech side. Every day you will hear about somebody getting a CDSO certification. These ECGs have become very portable. These digital stethoscopes are there, digital blood pressure machine. Every day we hear, right? And that is developing on its own and it's like a standalone ecosystem. Then you hear about the wearable ecosystem. Those are not medical grade, a lot of consumer grade, but a lot of these people have now started talking. We are capturing your vitals, basically giving you some fancy gimmicky dashboards, and people are getting it. Then you have this healthcare AI ecosystem where a lot of these screening kind of apps are getting. A lot of them are actually trained on synthetic data. That's beside the point, but it's developing on its own. And then you have the digital platforms, like one of the names you mentioned, where it enables delivery of services digitally, whether it's a teleconsultation, whether it's calling for a phlebotomist, getting medicines delivered, or even your EHR, medical records getting stored. Finally, there is a completely different healthcare ecosystem which has existed from forever, right? The physical healthcare ecosystem, hospitals, doctors. Nobody had got all these platforms to come and talk at one point. When we created the CureBay platform, we needed the medtech ecosystem because we wanted those devices to capture the vitals, right? We needed the digital platform because the records had to be stored. We needed the physical ecosystem to come into us because we could then share the information. So slowly and slowly, because of the need we had and the problem we were solving, we created this whole connected ecosystem play and allowed on one side we don't work with variables too much, but because that's a very much urban phenomenon. But who knows? Some days we, if we have affordable things making progress to it, because it's very easy to plug it into our system. Okay. So because of that need and the problem we were solving, we got all these ecosystems. Eventually, what we have done is on the demand side, we created a human touch, trust, high empathy model through our physical clinics, Swasthya nurses, pharmacists. On the supply side, we allowed the ecosystem to come and participate in this massive opportunity because now they don't have to build stuff. The platform has everything built in. You can come and plug yourself into the link and you have access to a lot of patients.
A lot of people talk of AI taking away jobs, but I really think this is how AI will transform us. Like people
Yeah,
who are
totally.
semi-skilled will be
Yeah,
as good as somebody who is highly skilled because they are
absolutely.
AI
You
powered.
should see some of my Swasthya Mitras, they don't even know it's AI product.
Yeah,
They
yeah.
think they're taking just images and uploading. It's an AI at play which is
Mm,
giving the report to their
mm,
friend instantly.
yeah. The AI is truly, I think, I mean, if India leverages it well, it's a job creator.
Absolutely.
Yeah,
Yeah,
yeah.
I shall. I love the conversation. Thank you so much.